welcome everybody to the monthly meeting of the Douglas County Board of Health. With that said, there is a copy of the Open Meetings Act on the south wall here of the meeting room. And if you're ready, Cindy, we'll call roll call.
Yes. Rogers.
Yes, here.
Wade. Weiss. Yes. Gray.
Here.
Espinoza. Here.
I have official notice of public meeting here. Item 2 is approval of the minutes. Note if we can add the minutes from the special meeting, well, and the date was July 27th. If that can be noted for the record to approve that. Is there a motion to approve both those sets of minutes?
So moved.
There's a motion to a second.
Second.
Roll call.
Rogers.
Yes.
Espinoza. Yes. Wilkin.
Yes.
Weiss. Yes. Gray.
Yes.
Any public, is there any public comment from anyone here wanting to speak? Okay. Seeing none, we'll go on to approval of the action items, items A through H. Is there a motion or second?
Motion approved.
There's a motion, is there a second?
Second.
Second. Roll call.
Gray.
Yes.
Rogers.
Yes.
Espinoza. Yes. Wilkin.
Yes.
Weiss. Yes.
We'll go to item 5 and issues for discussion. Letter A, the coronavirus update from Dr. Poole.
Good morning, board members.
Morning.
Morning.
I think I'm going to start out with two numbers that I think we should start to become a little bit familiar with, and that is the 7-day rolling average. That means for the last 7 days, what is our rolling average per day? And it is 111 cases at this time. Then on the national basis, you see it sometimes expressed as per million per day, so that we all talk about the same numbers, and that is for us 195 cases per million per day. Just a few more numbers for you. Up to now, we now have tested 115,568 individuals. That is 20% of Douglas County. We have, as of 8/17, and I just want to make sure that we all understand here, that's how the data goes. We always represent the data today, what has come in until midnight last night. So it may say on the news release, this is 8/18, but it is the data of 8/17. So we hear a lot over the last few days that people look at our news release and they say, well, but your dashboard says a different number. It is because we are very strict in the day we are reporting these cases. We have up to 8/17, 12,236 cases in Douglas County. As I have shared with you before, it is not very beneficial to look at everyday cases, but to look at the week as a whole, because that gives you a little bit the up and downs from laboratory reporting that we are getting. So last week, we had 861 new cases, and the week before we had 804. So you are seeing a slight increase in cases. Positivity rate, we had 10.6% last week, and the week before 9.9%. So a slight increase there too. Race and ethnicity, we have really not seen a lot of changes. We have Asians, 9% of our cases. Blacks, 10%, Hispanic, 37%. I just want to remind you, it used to be 54%. It's now 37% of our total cases. And whites at 35%, which used to be 17%. So we are definitely seeing a shift there. We do get often questions that we are not talking about Native Americans. And it is due to the fact that the percentage is very low. But I thought I just want to share with you, there are 68 individuals who are expressing themselves as Native Americans who have been cases of coronavirus. The age ranges, again, 32% are in our 20 to 34-year-olds, but we do have cases in our younger population. And I have done this once before, and I did it again last time, just looking at those age groups. When I look at 0 to 4 years, last week, we had 7 cases that were 0 to 4 years old. 5 to 9 years old, we had 9 cases. We had 24 cases, 10 to 14. The older we get, 15 to 19, we had 79 cases. So in total, what that shows you, just last week, we had 119 cases that were below 20 years of age. That's becoming a little bit more important now when school is starting. When we are talking about hospitalization, we are in good shape. I always say that, Omaha is a healthcare community. We have 250 med-surg beds available. These are staffed beds for an occupancy rate of 82%. We have 72 adult ICU beds available out of 360 staffed beds for a 79% occupancy. And we have 10 pediatric ICUs available. We have a total of 35 staffed ICU beds for pediatrics, 71% occupancy. Bless you. At this time, we have 109 COVID-19 patients in the Omaha area hospitals, 109. And we have 24 PUIs. These are persons under investigation who are waiting for test results but are in our hospital systems.
You call them PYs?
PUIs,
Okay,
person under
okay.
investigation. We have 115 ventilators that are in use at this time. However, out of a total of 454, and only 15 COVID patients are on ventilators. And we are seeing, that is shifting over the time of this pandemic. Physicians are saying ventilators are really the last resort. They have remdesivir, they have dexamethasone now that they are using, and so hopefully they can prevent individuals from getting on ventilators. The other statistics that we always need to talk about are individuals who died in response to COVID-19 or due to COVID-19. And up to this time, we have 145 on our dashboard. We are going to report 2 additional ones today, at least, as far as I know. So that would make 4 for this week, and we had 4 for the last week. So usually that's a number. 75% of those deaths are 65 years or older, and 61% of them are white. 14% are black, 20% Hispanic, and 3% Asians. Only 10% have no underlying conditions that make them at high risk for this virus. The good news is we have 8,257 cases that have recovered since the beginning of the pandemic. That is 67% of our total cases. And I cannot say enough for the people who follow up from our department on those individuals. By the way, I just need to stop. I cannot say enough about our staff. You should be very proud as board of our staff. They are working tirelessly. And to a point where yesterday when I met with them, there is absolutely a fatigue. This has been going on for such a long time. And so I admire all of them. I look at clusters, and I've shared with you before, we have up to now 417 clusters. Clusters meaning more than 2 individuals. And those 417 clusters make up 4,139 cases, 34% of our total case counts. That is, when contact tracing occurs, individuals are then identifying that they have been potentially exposed or been in those places then these contract tracers are putting these things together. The largest number of cases, and it has been over the last few weeks, is in our construction company. We have 52 clusters in construction companies. And by construction companies, we mean electricians, plumbers, small construction companies, 52 of them. They are small clusters, 2 or 3 people, sometimes only, but still 52 of them. The second one is our long-term care facilities. We have 47 long-term care facilities in this community who have had clusters or outbreak. And I just need to share with you 85 deaths from long-term care facilities. So from all the 147 deaths that we are reporting today, 85 are long-term care. The next cluster category is wholesale retail. That is small stores that have opened. We have 46 clusters that are referring to those. We have 37 clusters in food handler or restaurant staff, and we have 32 clusters in meat packing. And meat packing, you know, used to be one of our top clusters. It really has come down over the last weeks. It is, however, the cluster that has the most people in it. There are 1,465 individuals affected in those 32 meatpacking clusters. Just some other thing I want to share with you. Of course, all of our work, or a lot of our work is going on in school now with the guidance that we are providing to school. And, you know, the cross-reference that we have to do, the quarantining that now started and so on. So as of last night, our EPI department just gave me some data that I can share. We have now, since school started, 17 students that have come down with COVID-19, 18 staff, and 152 cases are in quarantine. You saw, again, the article this morning, and you see some of the schools that have been affected. One of our staff put a YouTube video together, actually for schools specifically, to share with them a little bit what is happening once a case is identified in a classroom, and that video is now also on our website. Long-term care, I think you know, they have started to do some baseline testing now so they can go into the next step, which is opening plans for those long-term care facilities. But what we are finding now is we are finding again that there are many more cases in long-term care over the last 2 weeks. Testing, you saw today the article in the paper, 50th and G is going to close. Potentially the end of this week, and we are looking now for another site for Test Nebraska, potentially in South or Middle Omaha, so to say. It's not so easy to find. We have Test Nebraska now at Oakview. We have it at Crossroads, and we have VNA who is doing some testing out on 138 and the West Center. But we want to have a site out down in South Omaha again, because even so there are some barriers. I do think not everybody has the same barriers, and there are some people who actually could easily go to Test Nebraska. It is probably the best testing that we have available at this site at this time. So we would encourage people to go and use Test Nebraska.
Is this solely because of supplies?
Well, to find a site, you know, requires some.
I mean the closing is because we were paying for that, right?
The closing is a supply, not a supply issue. It's a healthcare issue. He doesn't have enough staff anymore to actually be at that site. Remember, the contract is with Nebraska Medicine, and they are providing the healthcare providers to do the testing at the site. The contract was always through, I think we had it through the beginning of August, and then we extended it for 2 more weeks. But now what he's finding, or what they are finding, is they used to use some individuals who now are going back to college. And so it is definitely a nursing shortage. So you also know about the opening plans. If somebody had a gathering that they are planning and there were above 1,000 individuals in Omaha, they had to provide us a plan, and then we had a team who reviewed those plans. Up to now, we have 54 plans that we have reviewed and turned around. And we are really seeing a decline in those plans coming in. The Navigators, a team that is really busy, and that is the team that follows up when those cases are being identified and contacted by the contact tracers. One of the questions is, do you have certain needs? And if that family responds yes, then it will be referred to our navigators, who then will follow up with the family and try to see it. As I said before, the number one need is food. Food, utility, housing, transportation, mental health healthcare issues are coming up. So up to now, they have made 800 contacts and really are trying to stay with those families through those 2 weeks of isolation or quarantine. And after that, it is a Creighton group that now has trained or is training 50 community health workers who then will take up with those families and try to see, because potentially these were families who had issues before, so we really now need to integrate them and make sure that they can continue on. Our information line has received now close to 20,000 calls, 1,500 of them in Spanish. The questions they are getting are difficult. They are not just, what is COVID, what are the symptoms, or so on. They are people who want test results. If they don't get them quick enough, they want to know about the exposure guidelines. What does it mean for me? I potentially could have been exposed. They also still want to have some explanation on the DHMs, and now, of course, on the mask mandate. And with the mask mandate, I just want to share with you, they are keeping track of, and up to now, up to yesterday, we had received only 19 complaints on the mask mandate. Usually they can handle those. Usually they call back to business and explain to them what is required. And more than ever, the businesses, well, we just didn't know, or we will remind our staff again. So it has worked very well. There were 68 calls where people are calling and wanting explanation on the mandates, and staff is really good at doing that. So that's my report for today. Do you have any questions?
You're going to bleed into the other?
Yes. So then I have a few administrative issues that I just want to share with you.
Well, Dr. Paul,
Yes.
let me ask you one COVID-related deal. How do we take the fact that, I know it's like, for instance, Miller's been in school, seems like every day they've had a case. How do we judge that in regards to the school's capacity to be up? I'm just trying to think, at what point do you look and wonder if one case is too much, should they be in there? Because one case has people around it. And like Ralston had one, but Miller's been in this thing where they've had one every day. Now they're about to try to go into this restricted sports thing. I'm just trying to wonder how to look at that, being that you got a kind of hodgepodge around the district, around the county with school policy.
I can only go back and look back at when the athletic group started. In the beginning, the first week, we had about 20 athletic teams who had cases in them. And the second week, it was less, and the third week, it was less, because coaches were now really reinforcing that social distancing, mask wearing once you get off the court, and so on. So I'm hoping in school that maybe a little bit the same thing that we are seeing right now. I think schools are struggling with this a lot, because Some of them are in older buildings where they cannot really have a lot of social distancing or so on. So we'll work with them. The Global Center for Health Security is visiting these schools now too, and is making recommendations to them, what they should do different, and so on. So I think it is a little bit trial by error, so to say, but every school is slightly different. I have to share that with you, and every district is different, and the population that they are serving is different too. But everybody's trying just their hardest at this time.
So, not to put in, okay, another question. Explain to me how do we take the fact that, okay, I'm trying to judge how to take the testing thing. So South is closed. We were paying for South. South is closed because the testing facility, that's the one tied to UNMC, right? The one that was in South Omaha, because we were contracting with them. That's down because they don't have enough staffing. But Test Nebraska is up. How do you make that distinction?
Well, Test Nebraska,
Other than it's a private place.
I don't know. Test Nebraska is actually going out and finding staff, and they are going through staff agencies and so on. So that's kind of how they are doing it. So it's a good question, Commissioner, but I don't know. I just can tell you that from Nebraska Medicine, that's for them. They are down on their staff.
Okay.
And if some of you may have some suggestions for some sites in South Omaha, I'll be more than interested to hear that too. And don't forget, Charles Drew and One World, they are both having testing capacity at this time, and that will be ongoing.
Okay.
Okay, so let me just shift 3 things I want to share with the board. First of all, just staff changes. We had a resignation of our WIC supervisor, which is too bad. She only was on board 1.5 years. She went back to the university, got a position there to teach. So that position is open. We are advertising for that position. But in the meantime, also we have one new hire for Brian Burley. That position was open for a long time. Disease investigator. We hired a new individual, Emily. So we are starting to get back up to to some of our normal things that we do. The other thing I want to share with the board is an opportunity that we have through the Kresge Foundation. Some of you remember, we were in their group, Emerging Public Health Leader Group, and there is another opportunity now, and I think we are going to apply for it. It's not a lot of money. It's $50,000 for 1 year, but it is advancing public health in communities, and we think, especially with our ordinance about social, racial, I can't even talk anymore, the ordinance that the board passed about racism as a systemic issue, I think we will fit in very well. And so I think all of you, and I thank both of you for attending some of those meetings, I think we know that we need to move forward. And so I do think, and I hope you are approving us for us to go forward and intending to apply for this funding source. So I wanted to share that with the board. The other thing I wanted to share is just that the Nebraska legislature has adjourned, and there are some bills that actually have an impact on public health, and in a good sense. And 2 of the tobacco bills that were passed, one is raising the age up to 21 for individuals to purchase tobacco product, and the other one includes vaping in the Nebraska Clean Indoor Air Act. So those are really some really good bills. The other thing is LB 1008, and it's the budget bill. I think after the state senators went back into session in August, we felt very, very needy that we needed to get back to the senators and say we have some needs needs. We have some definite public health need. We have seen how the structure really is not strong enough to take on all these challenges. So we met with Senator Vargas again. Remember, he was the one who introduced the bill for local public health for $1.5 million for all the 19 health departments. So he was going to carry it in this short 5 weeks or so that they had back in, because we said he needed to go back and really ask for 6.5 million as our ask was the time before. And he's a good champion for public health. He has really realized how important public health is. So he went back to the Appropriations Committee, and in that committee, you know, they make decisions who then go forward to the full board. He got 2 million, 2 extra million. The bad thing is the way the bill is written, those 2 million are really due for local public health to be used starting in January 2021 for COVID-related expenditures. So, you know, that's not a bad thing, but we are also hoping that the federal government potentially makes more money available, and we would have preferred it probably to be more on a discretionary basis that we could do with those funds whatever we needed. But I think we always need to look at it. This was the only bill that got additional funding in this short session. So we are thankful for that. The 1.5 million are in there. We got notified yesterday that every health department is going to get $83,333 per year. So that's a good thing, and I just wanted to share with the board. If you see some of these senators, I think a thank you is going to be appropriate. And the last thing I wanted to mention is interim studies. There is actually a very interesting list of interim studies that are going to come up, but there are some that are really going to be of interest for us. One is to study, again, the long-term fiscal sustainability of the healthcare cash fund. How many times has that been studied? The other one that I thought would be of interest to you is, I think this pandemic has shown us where some of the authorities lie, and especially in regards to long-term care facility. Local jurisdictions really have no authority about it. It all has to do with the state. And as you can imagine, sometimes those wheels turn really slow. And so I think it is Senator Walz who is going to look at the jurisdiction of the Health and Human Services related to long-term care facility, assisted living, and nursing facilities. So we think that's a good thing. The other one is Senator Vargas is doing an interim study to conduct a comprehensive review of systemic and institutional racism in Nebraska. Wouldn't that be interesting for all of us? And he's also doing an interim study to conduct a comprehensive review of maternal and child mortality. And you know, those are two things that we really have worked on a long time. So we'll see if we can provide input to some of these interim studies, and we definitely will follow them. So that's what I wanted to share with the board this morning.
Regarding the interpretation and translation services, how many health workers in the department provide translation and interpretation services?
Yeah, those are a little bit two different things. We have a contract with Lutheran Family Services to do some translation. But we have also, I would say, probably 6 or 8 individuals internally who receive extra pay to answer phone calls in Spanish and actually talk over the phone in that language. So we have that internal capacity, but that's not translation. Translation takes a little bit more time, and that's where the contract is.
Okay, so the contract is
Lutheran.
strictly for translation?
Yep.
We have internal staff here who can do interpretation?
Yep. Yep.
And they get extra
They get an
compensation?
extra pay per month, actually, just to be available. You know, and they are all in different departments. Some in WIC, some are out here. So when we get those Spanish calls, those individuals will go down the list and they will answer those.
I noticed that the contract was increased. Is that presumably because of COVID in terms of translation with Lutheran Family Services? The increase in the amount of money?
And that could be, you know, because we need the translation at the testing sites. That's probably why that increase is, because we had like 3 Spanish translator at the 50th and G site all the time.
So, Dr. Poole, I don't think the funding issue, I think, is a good thing, but the fact is, they put the money in. I think you can always ask later
Yeah.
to let it be flexible. So right now, using it for COVID is related, so it takes some pressure off the other stuff. But I guess I'm trying to wonder how to do this, because I know staff time is strained, but, you know, I think we need to have some conversation if the board can help facilitate this, and I might have to lean on some people in the county office for this, because now that you've got their ear, I think we probably need to facilitate something with those people coming back that are on that weekly call, like Megan Hunt, Vargas, other people, to kind of walk them through this in the off season, so they know what they're going, what the relevant piece is, and I'm also thinking some of these people that want to be new senators, we might need to facilitate this discussion. So we can probably talk about it later, because I know workload-wise that may be, but if it's something probably that we may be able to just use county staff to facilitate it, since everybody here is still 100 miles an hour. I think we need to take advantage of the curiosity in it, because if Vargas's ear is turned enough and he's appropriator, then we need to walk that line real
I
hard.
agree completely with you.
So, other than that, let me bleed a little bit into item 7. So if anybody's got anything with that right now while we're answering questions. Because the one thing I want to ask you, Dr. Poore, and I'm just curious about it now. So under Dr. Figgs' report, I'm just curious in getting up to speed with all this, with mosquitoes, West Nile, flu. I know some of this stuff kind of cancels out when weather hit, but I'm just curious what Carol and you guys are thinking through when you got Ebola, the flu, West Nile, and mosquitoes, all this stuff working together. I'm just curious if there's any conversation with that about how, you know, extended seasons. My understanding of this is a little more keener now, having to look up on this infectious disease stuff and get a grip. I'm just wondering what the conversation is in respects to not only the flu and COVID coming together, but, you know, you ain't got a lot of people out, you got mosquitoes, you got transition. I'm just curious, is there any bigger concern long term with this about virus mutation, other stuff like that? And that's just more of a curious thought.
Not so much about virus mutation, because actually I think what we are seeing from the southern hemisphere is that actually the flu is down now. It seems like, you know, the prevention that we are doing with COVID may also have helped that. So I do not think, I think we have the first West Nile virus pool in Lincoln County. So it's August, you know, where we see most of the West Nile virus cases. So we are not through that. I think I would expect to see more cases. I think in general, from the infectious disease point, we always need to be ready for new emerging diseases. I think we are realizing we are only an airplane away from the rest of the world. And so to have a really strong capacity in a health department is really important. We saw that with Zika, we saw it with Ebola, and so on. So what we are doing, and actually I've forgotten to share with you, there is another grant that we are receiving from the state, and that is 240,000, but it comes in chunks of 120,000 per year. So it's over 2 years, 120,000 each year. And that funding is directly for disease investigation epidemiology. So what we are trying to see is, could we actually, potentially hire 2 individuals, but it is about increasing our infrastructure so that we can respond better. The other thing that really is important and that we shouldn't forget are these huge data systems. We are using, at this time, 4 different data systems that talk to each other, and it's very, very cumbersome, as you can imagine. But this comes from the state, so we need to see changes at the state, who now put out an ROI to actually see what systems are other states using, what systems are available. So data for infectious diseases is extremely important, and so we need to ramp that up and find a better system. And the governor is very interested. So I would say, so that we can be as strong as we can be for emerging diseases.
Well, I'm just assuming since we're in a drought, there's not a lot of West Nile opportunity because there's not a lot of pools gathering. So my last question on that is, and again, it's just in trying to prep through this. So, COVID will happen, but I keep thinking now, the infectious disease part is going to basically I think the example that I kind of gave of when 9/11 happened, things went to another degree, and it's like always there. So now you have that same thing with infectious disease. Is there if you get this other person, I know it's mostly the state, but the point that you made is that travel really eliminates this deal now. So it doesn't matter if you're over here, travel can bring it in an instant. And we always got to be on guard for it. But being particularly that you're an ag state, you have to do a lot of work with China, where a lot of stuff is originating. I'm just thinking, again, more future and preparatory wise, how we need to man up in regards to those 2 positions, just trying to really be able to sense this deal. I'm hoping, depending on what happened election wise, something's gonna happen to make that sense a little stronger. But I'm just hoping you all are, and also can advise the board to help trying to put together, just some coalition to keep us on point with that, because, my thing now is that I don't want to be caught off guard with this again. I almost feel like, they put the locals on their own on an island. So if that's the case, then I almost feel like we got to ramp up forward and be ready. So I just put that out there.
I agree with you, Commissioner, but to that, I also do have to say we are fortunate in that we have some good infectious disease docs in our community who are really willing to give their knowledge and their help to the health department. We are on calls with them twice a week, actually. Which sometimes can be a little bit interesting, because there you have the academician, on our side you have the practitioners, and sometimes that doesn't always flow together. But to you, I would just say we really need to have a strong surveillance epi group in our department.
Is that something we need to strengthen more, or create a little more on its own?
If you would ask staff, they would like to have more staff. So, but it needs to be staff who is now at a little bit even a different knowledge level.
Are they got a plan they putting together with that?
They would put a plan together for you in a heartbeat.
Can they do that? Okay. All right. Anybody else?
Dr. Adikar, going back to the testing site, there's several locations that I
out, or is there an opportunity to bring in other health systems, such as CHI Health or Methodist Health Systems, to help us staff those locations?
Yes, and we have reached out to all of them and have not been taken up on it. So, but, you know, it may be a different time, maybe a different person, there may be a different response. But we have reached out to all of them.
Anybody else on item 5 or 7? All right. With that, let's go to item 6 in presentations, mental health and ACEs.
Could you move the camera? There's a presentation going. Thank you.
Good morning, Board.
Morning.
I believe everybody has a copy of the, hard copy of the Mental Health ACEs Call to Action Report. I'm not going to go into it into a lot of depth, but I do want you to know that it's very steeped in data. There's multiple data points. It's written from a regional perspective, but there's also Douglas County specific data in there. So I want to just bring a couple of things to highlight. So remember, this is the first time ever that we've asked ACEs questions in our community health assessment. So this really is the start of our baseline here in Douglas County as well as across the region. However, there is data through the CDC. So just a little bit of history. The ACEs actually came about back in the mid-1990s, 1995 and 1997, with a partnership with CDC and Kaiser Permanente, and they developed these categories and these 11 questions that now are asked across about 25 different states. So CDC really has probably the best baseline data that we can use to compare our local data, regional and local data. And so a couple of points I want to bring up, because I don't want this to be perceived as just because this is the first time we've got this data, we're probably not where we want to be. Quite honestly, a lot of our data is better than what we're seeing at the level of CDC, but we do have room for improvement. So I just want to kind of give you a flavor of where we are with that. So the first one is over 60% of metro adults report experiencing at least one ACE, according to the CDC, and their data is really from 2011 to 2014. So it's over a 3-year span of time. In my opinion, it's a little dated, but for whatever reason, they just haven't updated that, and I think it's because they're really dependent upon the state doing their data, and it comes from the behavioral risk factor surveillance system data. So every state does that data set and that data analysis a little bit differently. More than 1 in every 3 residents, 37% experienced emotional abuse as a child. We're right on par again with CDC compared to the BRFIS data. We're actually just a little bit higher, maybe at about 38%, so not a whole lot of difference. The 1 in 4 respondents, 23.6%, experienced parental separation or divorce. We are a little bit lower. CDC is around 27%. 15% reported 4 or more ACEs across the region. We're actually better than CDC's data point. And then the last one is more than 1 in 4 respondents, around 26% experience household substance abuse as an ACE. And that is, we're actually lower than the CDC component. The reason I picked these 3, emotional abuse, parental separation, and substance use, is I'm going to show you in a minute. That's actually the 3 highest that we see across the region that really were pervasive as far as the respondents on the survey study. So this data is from the region, so you can get a sense of the respondents. And so as a reminder, these are adults answering questions based on their experience of childhood from birth to 17 or 18 years of age. So there's 8 categories, but there's actually 11 questions. So there's 2 questions around kind of the physical abuse component and 2 questions around substance use and the mental health. So this gives you a sense of how we're breaking this down by county. So the categories are across the bottom. Douglas County is in kind of the reddish rust color. So you can see how we compare to the rest of the counties, again, based on those categories and what the percentages of the respondents are. Not a whole lot of difference. We're certainly better in some areas than others as we compare to the other 3 counties. But it gives you a sense that we're all kind of, for the most part, starting at the same starting point as we think about the action plans for this. What I did want to see, and we had a press conference last Friday, and we didn't really go into the local data very much. It was really just to bring forth the report that was out there and begin to have some discussions, raise the awareness that the report is out there. But because we do an oversampling of data here in Douglas County when we do the community health assessment, we have data that actually shows the ACEs responses according to region. So we around our data use 5 regions. So there's Northeast Omaha, Southeast Omaha, Northwest Omaha, and then Southwest Omaha. Then Western Douglas County, and then we compare that to the whole component of Douglas County. So now you can see where we do have some rates that are worse than the CDC BRFIS data baseline. So in, for example, the emotional abuse, which is probably one of our top 3 significant concerns, we have higher rates in our Northeast and our Southeast regions. The same with household substance abuse, that's heavier, a higher rate within North Omaha. Parental separation and divorce is higher in North Omaha. But you'll also see some of them where North Omaha and South Omaha aren't all that different, and there was actually a higher rate in Western Douglas County with physical abuse. So we do certainly have some pockets of need within South and North Omaha, but this is really pervasive. Sometimes when you look at this data, race doesn't matter, geography doesn't matter. It does certainly, but pervasively when you look at this as far as a county approach, we have work to do across the entire county. So this gives you a sense of what the breakdown looks like across our region versus kind of the metro higher levels. This data does show, and this is metro region, this is not county specific, but it does show our breakdown within the region. And so this is the score of ACE or more. So as individuals were answering those 11 questions, if they answered yes to more than 4 of those questions, they were identified as having an ACE score of 4 or more. So we do have some concerns definitely within our community, specifically in Northeast Omaha. And again, a little bit higher rate in Western Douglas County, which I think some of us found a little bit surprising. This is the prevalence of ACE scores 4 or more, again, broken down by gender. Interestingly, we have higher rates within the younger population versus the over 65. Not a whole lot of difference with the income, a little bit higher rates between very low income, but then we do see some higher rates in mid and high income, and then higher rates within the Black, non-Hispanic, and then other, however they identified the races they were answering the questions. And then we asked PRC to really connect the ACEs response to what we kind of categorized as lifelong health. These are questions that are asked throughout the rest of the community health assessment. So we always ask about, say, for example, excessive drinking. So PRC was able to link the ACEs responses to the responses of excessive drinking. So you can see the most significant concern for those that have ACEs. The blue is I answered no, I've not had any. The low ACE score is 4 or lower, and then the high ACE score is the red. So that says that if you've got a high ACE score, you answered 4 or more, yes to 4 or more questions, you have a higher difficulty accessing healthcare. And I want you to remember this because I'm going to talk a little bit about how we're going to be focusing with this on our next CHIP work. And then you can see across the categories. So higher ACE scores are connected to a diagnosis of depression. Higher ACE scores are connected to, I'm a caregiver for somebody that may be caring for children, I'm caring for a senior parent, higher rates of excessive drinking, and so on. So this really gives us a good roadmap to begin to think about what our CHIP work is going to look like here in Douglas County. So it's not all bad news. So across the CDC and really across the nation, ACEs are very common. This isn't anything that's unique to our community, unique to our state. They're very common and they're very preventable. So many of the things that we're going to begin to look at as we develop an action plan is when we think about children in the home, what kind of policy systems and environmental changes do we need to think about as a community to really protect these young children, to limit those exposures to these adverse childhood experiences. This is everything. So for example, we do have some things that are already happening in our communities. So for example, visiting nurses and the Nebraska Children's Home Society is already doing a home visitation called the McVee. So we've talked about the McVee grant before. We had that internally here, and then we partnered with both VNA and Nebraska Children's Home Society. So they're in homes of new parents. Many times they get a referral from a physician. They're pregnant or have just had a child, and the healthcare provider identifies them as needing additional needs. So that staff, many times it's nursing staff, are going into those homes to help navigate a whole slew of whatever those challenges might be so that they're really providing the supports to that family unit as those children are growing up. So part of it too is a lot of parental training. This will connect definitely to the Trauma Omaha Matters with the trauma-informed care that's coming out of Project Harmony, which is part of our CHIP. This talks about changing the social norms. The racism as a public health crisis will be embedded within this work. So this really, the roadmap, CDC has developed a roadmap. What that will look like unique to our community will come from the action plan that we develop with our partners. So because this is really the first time we've ever done this. This is the first report. It took a long time to get out. There were a lot of hands in the pot, and so there was a lot of opinions. We did send it out to many community partners to give us some feedback. For those that really love data, they're going to trip out and probably could be connected to the community health assessment on the web. But there's also storytelling in there. So we really wanted it to link to the mental health component, because you can't do one without the other. We wanted people to really feel a personal connection of those that are living with mental health or supporting those with the diagnosis. So this ACEs report is really just an opportunity to educate the community, inform, provide the opportunity for people to read it, digest it, ask questions, bring forth concerns, ideas. And it really is a call for the community members to come join us in our action plan moving forward. So I want to talk a little bit about the CHIP, because this ACEs report was part of our CHIP moving forward. So as a region, these are the 4 categories that we're working on. I think I've mentioned this before. And Sarah, Shirley, and Sheena Helgenberger were here last month talking about the launch of the mental health anti-stigma campaign. We also are going to be working on, and the last 3, the mental health resources and the isolation and loneliness came from community members as we did those those community meetings that were just come tell us what you're struggling with, what your concerns are, what your ideas are. So they really want us to figure out, work with them on how we can either identify, build, or connect them to the mental health resources in the community and address isolation and loneliness. And then we've added the ACEs call to action report as far as just launching this. I just want to remind you of the mental health stigma campaign. So there's really 2 overarching components. We really want to support people telling their story. It can be anonymous. It can be, I live with a mental health diagnosis, or I'm supporting with someone, so that we really begin to normalize the conversations. Just like I say I have diabetes or hypertension, I live with and manage my depression and my anxiety disorder. So there's a couple of different components. One is to share the story. The other one, I'm still quite, there's research this works, but if you load a picture of your animal, whatever that may be, and tell the story, and it doesn't have to be about mental health, but many times that's what bubbles up. Again, it's normalizing that conversation and talking about the supports that individuals have through the animals in their lives. We do have 4 resident engagement catalyst projects, so you may remember we had about 4 or 5 meetings with community members to get their ideas and gain their input. So we actually have 4 work groups: Advanced Directives for Mental Health, that's being led by Legal Action, Community Legal Action, Legal Aid. Creative Expressions is a group that's led by a couple of gentlemen, one from Potawatomi County and one from the CHI Health Systems, and they have got a lot of energy and great ideas, and they have a pretty active group that's pulled together. Resident Dinners is being led by the Wellbeing Partners, and then Trauma Matters, we're having conversations with Trauma Matters Omaha under Project Harmony to see how they might be able to expand out the training program that they're doing around trauma-informed care across the region. Right now they're just specific to Douglas County. So what's happening here in Douglas County specifically? So while we're doing regional work that includes Douglas County, we also have a number of initiatives that are going to be happening locally too, as well as part of our CHIP. So remember the high rates of those with ACE scores 4 or more that have difficulty accessing to care. One of the things we decided that we don't really have a good sense or a true understanding of what the mental health resources are out in the community. And just because there's a resource, what does that mean for eligibility and copay and transportation and literacy and all the components that make it easy for individuals to find a link to? Children's has already started some of this work, and we are then going to connect it to an access to care work group that we need to do as well. I mentioned the Trauma Matters Omaha. I do want to acknowledge what the work that we've been doing in our STD clinic with our behavioral health consultant that right now is on hold, but we found extreme value as we were screening for depression and substance use within those coming for STD clinic services. So we want to make sure that that becomes really embedded and part of our standard of care. We're taking an active role with the Kim Foundation as they work on suicide prevention. We just had our first meeting yesterday with housing and mental health. This is actually a grant that was awarded to the Wellbeing Partners there was probably 25 partners on the phone yesterday. It's a planning grant to think about those that are medically complex, both physical and mental health, and their homelessness, so Match is the lead on that. But planning for how we're really identifying those individuals as they get discharged from the hospital, what their physical and mental health needs are, in addition to their homelessness, and planning for what that is going to look like as we think about preparing for an implementation grant. We are going to be launching depression screening. It's a pilot within our WIC population, so individuals, moms who are pregnant and or postpartum, or pregnant and then postpartum. Every visit we will doing a PHQ-4. The registered dietitians will be screening those, scoring them, and then referring them out if they get a high score. So we're going to be launching that in October. We do have an integrated care work group. This is actually a carryover from the previous CHIP. This is a very active group. It revolves all the health systems, including children's, as they continue to work to build integrated care, meaning that they have a behavioral health consultant component embedded within their health team. So it's not, here, make a call for mental health services. It's right here, I've got somebody to meet with you, talk with you, and figure out what your needs are. And then we do want to make sure that we're linking the Housing Ombudsman Initiative, because when you think about housing, we all recognize that's significantly impacted by health, both physical and mental. And we want to make sure that we embed that mental health component as we launch that initiative within the county. I think that's my report. Any questions?
I do have a couple. So just to clarify, on the regions within, when they're talking about northeast, southwest,
Yeah.
what's the dividing line? Is it 72nd and Dodge, 90th and Dodge? Do you recall?
I don't know exactly on our website. So Richard, through the Vital Statistics team, I don't know if it's clear. It might be.
Okay.
There's maps on the website and there's red lines that kind of.
Yeah, I'm trying to remember. It's one of those, but
I don't know if it's
remember.
exactly that. I'll be honest with you.
Okay.
I don't know if Dr. Ford knows off the top of her head, but
Okay.
72nd?
Is it 72nd or 90th?
72nd.
72nd.
Dodge.
Okay.
And west, I have a little bit more difficulty to tell you. So there are 4 quadrants, and then the western part goes, I don't know what that is. It's kind of the
Okay.
county, Elkhorn Valley.
The western part would be Bennington Valley,
Like
Waterloo,
144th, maybe west.
a little further than that.
156.
Probably a little further than that.
Okay. Also, I'm just thinking through, like, from the CHIP process, the work the community is doing in this area, and recognition that it may take like a full generation before we see, because you're talking to adults about their childhood experiences. So it's just going to take, this is a long term.
definitely will be a marathon. Yep.
Yeah.
Yep.
Okay. And then on those lists of items that the CHIP is working on, that first one around mental, behavioral health, resources, et cetera,
Yeah.
is Region 6 and System of Care folks involved in this work as well? Is there close intertie or?
Yeah, Crystal Fuller really has been on board. She's kind of leading the anti-health stigma campaign, and she's got staff through Taryn Peterson that's going to be helping us with this, as well as all of their partners.
Okay.
So definitely, yep.
So I just know there's all the System of Care work occurring as well, and I just want to make sure.
And actually, within the mental health stigma campaign, we have a mental health advisory group, and so that's probably close to 40 people that are all either direct service providers or connected to in some way. So all of those are going to be involved with this environmental scan too as well, because it's so massive, and it's sometimes very fluid, just depending on funding and
Yep.
what it takes to build that capacity up. So yes.
Okay, great, thank you.
Carrie, let me ask you. So how do you think this helps us make the stronger case for YRBS? How can we use this to make the stronger case for that? What cycle are we on with that? Are we is that coming next year?
Well, actually, we decided to skip a year because we were doing it every other year, and we found that it was such a struggle to get the data that we needed. So Dr. Poor and I were working with OPS staff and their data, and then the Women's Fund.
Okay.
And that actually, we were kind of making some inroads, but then COVID hit,
Yeah.
and so that's all really been put on the back burner. If you'll notice in the report, I did include some of the concerns around the YBRS data specific to mental health. So I have the suicide, consideration of suicide that Dr. Poor presented on last year that was of concern. So it's directly tied to that. So as these children are experiencing whatever they might be experiencing within their homes, that's directly tied to their rates of depression, anxiety, school performance, suicidal ideation, absolutely.
So, I'm just curious, I'm assuming, well, they may not have, but I'm assuming since a lot of stuff is trying to convert, do you know if, because the CDC gives this, right?
The
The
CDC,
CDC gives the YRBS. Technically, does it go up through CDC? Or
it
what?
does, and then it works with the state partners, yep, down to the locals.
So I'm assuming they're making some way to do this paperless. I would assume in being with everything going on.
I haven't heard of anything.
Well, if we make that assumption, I'm assuming now with this report, once they settle down a little bit in a couple of weeks, this may be a good time to approach them because they're, and I'm saying the school districts because their concern is heightened with this mental health piece. YRBS may be a little more acceptable.
Yeah.
So I don't know if we want to make that. I guess the other thing is, should we, you mentioned these other groups. I want to know, should we add, like you're doing this screening in the WIC population, you know, I actually would like to add the jail and and DCYC to that. Because everything you're saying correlates to the fact that I'm thinking there has to be some correlation between the high mental health numbers in the jail and just some of the stuff that you see in the kids over there, that if we can make the correlation, that makes a whole better case up front for some of the stuff that you're trying to do.
Are you thinking just the depression screening or all the
I'm
ACEs
thinking whatever
questions?
we got to try the ACEs piece. I mean, is it worth paying? And I think you might be, because it's worth paying to go in there with those populations and asking those ACEs questions. Did you have this? Did you have that? And if that's the case, to me, if you tie that together, you've made a case for a lot of upfront stuff that people have been saying that they do, but this there, particularly if you got 60% of the people in that facility that have some form of behavioral health or depression. So if that can be talked about, I would love to have that kind of done and looked at. Matter of fact, if it's a way to formally just make it a fact of, to all the other stuff we do, ask them this question and ask them to take it, to tie it together, because I think it's all relevant. Okay.
Yep.
And I actually think that information, on another point, I actually think that information helps build a better case down the line for this discussion that happened yesterday at the council about money going other places. So you can probably weave a lot of stuff in on this and make it go. So, anybody else? All right.
Thank you.
Carrie, that's good. But while you're there, let me know, because I'm bringing under this because it's relevant. So, based on what Carrie's got there about the housing piece, we had talked about this a while. Actually, this conversation came up before Councilman Gray was on, when Councilman Jerem was here. Dr. Poor, I forwarded to her, and she forwarded to you all, and I would like you all to give some thought to that. The resume from David Levy. I think I don't know if he's the chair, but he's a member of the Omaha Housing Authority's board, and he's got some housing experience. So we've talked about it for a while, and it may be time now, particularly with this and the other initiatives going on, to have that housing ex officio on. So you have the public safety ex officio, the transit ex officio, and the housing piece. And so if people are fine, I think he's got a legal background. He's on that OHA board that helps incorporate some policy in there, and he's got some dealings in the housing community that will help us work our way through there, I think. So if you all want to just look at that, give some thought to it, I'd like to get your feel on it and feedback. And if I don't hear anything from it, I'd like to put it on next month's agenda for ex officio. Good.
I'd like to say just a little something now about David. David is also, first of all, I'd be highly supportive of David, being an ex-official member on this board. You know, David is, you know, besides being, and he is the chair now of the Omaha Housing Authority Board, but he also has been working with me when we created the landlord registry. David was very instrumental in working with me. He represents a good portion of the apartment community here in Omaha. And so, you know, he has extensive background in it, a lot of good work in it. Very dedicated individual. He, you know, we had conversations, you know, a couple of weeks ago where we were talking about evictions, and the Omaha Housing Authority, under his leadership, finally came to the conclusion that, you know, even though the actual dollars and everything have run out in terms of, you know, paying rent and so forth, the Omaha Housing Authority, the only evictions that they would be doing would be based on criminal activity and other things like that. Absent that, they put a moratorium on evictions in Omaha Housing Authority. So he has extensive knowledge. He's worked well with, and this was a group that I put together that had him on one side and, you know, some of the housing advocates on the other. Mr. Fish, I can't think of his first name at Family Housing. He's
Gary.
also been, and so, Gary Fisher. And so, you know, in a room with these guys, David has worked well with them. We're going to make some tweaks to the landlord registry, and David's been very helpful in helping us come to a meeting of the mind, so to speak, something that everybody can live with in terms of this, in terms of the rental registration, and so we're moving forward with that. There'll be legislation on that coming up fairly soon. I also want to remind everybody, while I have the floor, Mr. Chair, for a minute, is that next week will be the third reading for, as you know, the City Council took 2 tracks in this mask mandate. The first track was an emergency mask mandate, which we passed last week, 7-0. But there was also another ordinance that we had, so that if, you know, this mask mandate runs out September 15th. And so what we have in place is another ordinance that'll be on third reading and vote next week if we wanted to, that will, if necessary, replace that mask mandate if we don't get enough votes for another emergency, you know, depending on what Dr. Ford tells us about, you know, where we are at that particular point in time. We do have another ordinance, and so we can, and this one only takes 4 votes. And I know we've got the 4 votes to do it. The mayor won't veto it. So we do have the ability to extend the mask mandate through either another emergency ordinance or the ordinance that we will be probably approving next week.
Let me just say with that, I mean, I do want to thank, and I think the board should take some pride in this. Actually, the origination of it goes pretty much back to the board had this conversation probably 6 or 7 years ago about wanting somebody on the council for this specific policy purpose. And so even though, and I think the board should take some pride in the action on the 27th that kind of spurred this debate and put it there. So from the long range part, the foresight of the board back then to have a policy person from the council on to understand the gist of it pays off now. And so that's kind of the hope in all these different ex officios to tie this piece together. And I think hopefully we see by Carrie and all the other pieces that we tied together and able to make it go. So I want to thank them on that, and the board should take some pride in that foresight for being able to connect those dots together. So any other questions on that? So I'd like to go to item H, which is committee reports, and I don't know if Ms. Wise and Ms. Espinosa wants to talk a little bit about the conversation they've been having with staff.
So we've only just had a very initial conversation. We're meeting later this month, the next week or so, and of potentially doing a health equity committee within the Board of Health that would be a mix of board members but also community members to really serve as one sounding board for the Douglas County Health Center and their staff, Douglas County Health Department and their staff as they do this work, but to also serve as an accountability of just making sure that this doesn't get forgotten and that continued progress and this keeps moving forward is occurring. So we will be talking about what the name of the committee needs to be, makeup of the committee. We're anticipating 7 to 9 total committee members. So that's kind of where we are at this point.
Okay. I almost feel like you should, you know, it's come back around. I almost feel like it needs to be named the Frank Peak Equity Committee. I know it was, I think Marty was here. I had a privilege at the end, Dr. Philippi, when I think a lot of that originated when he was there. Then we merged it when we went to the social determinants of health, but now it's made its way back, so I almost should have his name in there somehow. But with that, they'll look forward to that committee's work and report back on that to fulfill those acts within that resolution.
And we'll probably be bringing back, we'll be working to create a charge for the committee. And do we need to officially approve the committee? Like, is there a motion
Yeah, I think
that
if
we
you
need
all,
to go through?
yeah, if you all want to have a charter, I think we
Okay.
can officially do it so you know what the purpose is and we can approve it from there.
Okay.
Okay. All right. With that, there's no need for executive session. If there's no other updates, is there a motion to adjourn?
So moved.
Motion is a second.
Second.
Roll call.
Okay. Gray,
Yes.
Rogers,
Yes.
Espinoza, Wilkin,
Yes.
Reese.
Yes.
All right. Thank you all.